Yes, sir. It's fine.
Okay, see the slides and I am audible, right? Okay. Today's class is a short class one, and we'll discuss about hematuria today. Okay. So I'm audible, right?
Yes, sir.
Okay. Okay. I'll go ahead. So this is a short class, maybe half an hour. We'll finish, but it's important topic. And so hematuria means blood in urine. So whenever a patient complains of hematuria, you need to think some important points like it's an important symptom. The patient whenever a patient comes with hematuria, blood in urine, this is an important because a lot of diseases are associated with it, and sometimes it can be life-threatening also. But you should know whether this is true hematuria or false. So whenever you encounter a patient of hematuria, first of all, you need to make sure this is hematuria or something else. So what are these something else can be? Number one, it can be concentrated urine. Sometimes a patient, dehydrated patient, when they look at the urine, this is dark yellow in color, they fear of blood and they come to you saying that I'm passing blood in urine. That is one. Another is it can be hemoglobinuria or myoglobinuria. These are the product of this RBC lysis because of lot of things, and these pigments also when they pass in urine they look like red in color. Other very important thing you should not miss is sometimes pigmenturia, like drugs, like you can see rifampicin or phenolphthalein. These drugs contain some of these pigments. When they are excreted in urine, the urine they color the urine red or pinkish in color, and the patient may regard it as hematuria, and they come to you. Sometimes food coloring agents like beetroot. When a person eats beetroot, the urine becomes red. Similarly, coloring agents like the sweeteners, food sweeteners contain colors, and these coloring agents may be excreted in the urine, and they might impart red color to the urine, and the patient will visit OPD like they are passing urine. So whenever you get a patient with hematuria, take this history, whether they are taking some drugs, food or coloring agents, and they have conditions which can lead to hemoglobinuria or myoglobinuria, and whether they are severely dehydrated, passing concentrated urine or not. And you can examine a sample of urine. You can ask the patient to go to washroom and pass urine in the bottle, transparent bottle, and get it back. And you can see whether this is just concentrated urine or this is really blood in the urine. So these are the things which can mimic hematuria, and you have to rule out these things before you evaluate the patient. So let's talk about significant hematuria. All hematuria may not be significant. So significant hematuria, either it is gross hematuria is significant or microscopic hematuria with more than 3 RBCs per high power fill in 2 out of 3 consecutive urine samples. This is regarded as significant hematuria. So if the patient has gross hematuria, that is significant on its own. And if the patient, some routine investigation, you see RBCs in the urine, and if these RBCs are more than 3 per high power fill, and that is also in 2 urine samples out of 3 consecutive urine samples, it's regarded as significant microscopic hematuria. So these hematuria needs further investigation. If you find a patient with a simple 2-3 RBCs in a single occasion, that may be not significant. That patient needs follow up with further investigations. But if in further investigations there is no hematuria, then that is okay. That doesn't need any treatment. So in clinical evaluation of hematuria, you ask 4 questions to yourself: whether this is gross or microscopic, timing of hematuria, like whether this is in the initial part of passing urine or in the end of the urine voiding or throughout the voiding process, whether that hematuria is associated with dysuria or pain, and whether there are passages of clots or not. Sorry. So these are the 4 questions you ask yourself, and if you get the answer, it's easier to make a diagnosis. Gross or microscopic hematuria, why it's important is, if there is gross hematuria, it's already becomes significant and there is certain underlying pathology, and the chances of identifying that pathology is more in case of gross hematuria. In microscopic hematuria, sometimes we may not be able to find the exact cause. Sorry. Timing means whether the blood is mixed with initial part of the urine, or blood comes at the end of voiding act, or the blood is mixed throughout the sample, throughout the voiding process. So initial hematuria, if the patient gives blood is mixed with urine in the initial part only, then probably the source of bleeding is from urethra, like urethritis or some vascular anomaly in the urethra, or urethral papillomas, these things. If this is terminal, only end of the voiding act, the blood is mixed with urine, then probably it's from bladder neck or prostatic urethra. What happens is, in the when the patient passes urine, the dilated venous, especially in chronic retention of urine with large prostate, there is vesical piles, which is dilated veins in the bladder neck, which are when the bladder contracts completely at the end of passage of urine, these blood venous channels, they rupture because of collapse, and they pass blood at the end of the maturation. Total hematuria is whole urine from the initial to the end, from the start to end, is mixed with blood. If the patient complains of total hematuria, the reason is probably it's arising from kidney or upper tract, or continuous bleeding from the bladder, like bladder carcinoma of bladder. So in carcinoma of bladder or bleeding from upper tract, whole maturation act, during whole maturation act, the urine is mixed with blood. Another is pain. It is important to ask whether that hematuria is associated with pain or burning sensation or not, because by asking this question you do a lot of diagnosis. If the hematuria is painful, that is associated with burning sensation or pain in the suprapubic region, then most likely diagnosis is infection, cystitis, or there can be stones that is present in the ureter and the patient is having colicky pain, or sometimes it's bleeding from upper tract, like transversal carcinoma of the renal pelvis, and bleeding from that, and that clot formation in the ureter is obstructing the ureter. That also gives rise to pain. So painful hematuria, differential diagnosis is either cystitis or stones in the ureter, or bleeding from upper tract with obstruction of the ureter by clots. Another is painless hematuria. The patient just notices blood in the urine but doesn't have any symptom. This is painless hematuria. No dysuria, no frequency. He just visualize red urine or just passing blood per urethra without any other symptoms. Painless hematuria. This is more dangerous because painless hematuria, number one different diagnosis is malignancy, most likely carcinoma of bladder. So if the patient says the carcinoma of bladder, the feature of carcinoma of bladder is painless, profuse, periodic hematuria. So one of the first differential diagnoses of painless hematuria is malignancy of the bladder. So another question you ask whether there is clots or not. If the patient says there is associated clots, then that signifies significant bleeding and appearance of the clot also. If the clot is vermiform, slender, tubular clot, then probably this blood is coming from upper tract, renal pelvis or ureter, and most likely diagnosis is malignancy of upper tract. So by looking at the clots and presence of clots, you can get some clues about the diagnosis of the cause of hematuria. So besides these things, when you evaluate the patient of hematuria, you need to ask certain other questions like irritative voiding symptoms like dysuria or urgency frequency. These are present in cases of urinary tract infection. Fever, again, pyelonephritis, or cystitis. Sometimes there can be exercise-induced hematuria. Vigorous exercise can also cause hematuria. So ask the patient whether he had vigorous exercise before the passing urine or not. Similarly, in females, menstruation, if the hematuria lab in the report shows RBCs in the urine, you have to ask whether that was during the period of menstruation or not. Drugs, we have already discussed like rifampicin, phenylphthalein. These gives rise to colored urine rather than hematuria. Whereas other drugs like NSAIDs, these can cause true hematuria also. So check drug history also. And similarly, colorful foods like sweets, food sweets, and rhubarb, beetroot. If there is a history of ingestion of these foods, then you can say this is probably not hematuria, true hematuria. This can be just coloring of the urine. And family history of glomerular disease. Certain glomerular disease can run in family, and if this is present, probably the patient is having glomerulonephritis type of disease. So on examination, what you look at patients? First, look at the fever, blood pressure, and presence of edema. This fever indicates the presence of urinary tract infection as a cause of hematuria. All these the patient comes with hematuria, but your job is to diagnose the cause of hematuria and treat that hematuria. So all this history at examination we are doing to come to a diagnosis of cause of hematuria. So fever is present, probably causes urinary tract infection. If there is blood pressure or edema, probably this is glomerulonephritis, renal parenchymal disease. If there is flank mass or renal angle tenderness, probably this is because of stone or malignancy of the kidney. Huge bladder tumor or bladder stone. Presence of urethral discharge indicates urethritis as a cause of hematuria. You have to do digital echo examination to see the prostate, whether this is BPS or CA prostate, carcinoma prostate as a cause of hematuria. And you also need to examine skin for petechial rashes or features of vasculitis. These are present when the patient is having hematuria because of coagulation disorder. So all these stone may be in the kidney, ureter, bladder, or urethra. All these stones can give rise to tumor of origin coming from renal cell carcinoma, Wilms tumor, cancer cell carcinoma and papilloma of renal pelvis, ureter, bladder, urethra, and carcinoma of prostate. All these can cause hematuria because they are in the urinary tract, and bleeding from these and BPS itself can cause hematuria because of enlarged veins in the bladder neck. And don't forget about asking the history of hemophilia, sickle cell disease, and their geographical regions and their siblings affected with this disease. And similarly, glomerular tubulointerstitial disease like interstitial nephritis, glomerulonephritis, IgA nephropathy, all these can give rise to hematuria. And use of anticoagulant drugs like aspirin. Don't forget to ask this history also. So diagnostic test. After history and examination, what investigations we do to diagnose the cause of hematuria? The first and foremost is the urine routine, cheapest and easiest investigation. In urine routine, what we see is, first of all, we see presence of RBCs. RBCs, how many RBCs per high power fill, or plenty, or less than 3, more than 3 is significant. So besides RBC, what what we look in the urine routine is proteinuria, presence of protein and cast. Presence of protein and cast indicate glomerular disease because cast are deformed RBCs, and when these RBCs are leaked through the glomeruli, they come into nephrons, tubules, and while passing through these nephrons, these RBCs get the morphology of RBCs get changes and they become irregular. These are called casts. And presence of leaking of protein through this glomeruli, these are also indicate glomerular disease. Whereas presence of WBCs and bacteria in the urine routine examination indicates probably the infection as the cause of hematuria. So phase contrast microscopy is a special type of routine examination urine sample where they specially look for morphology of RBCs. As I already told you, if dysmorphic RBCs are those RBCs which leak from the glomeruli, through nephrons, tubules, and come to the pelvic calcium system. During this passage, this RBC get crenated or their morphology changes. They entrap and they pass through a lot of stress, and these are morphology changes. If these are called dysmorphic RBC. Isomorphic RBCs are those intact RBCs, those bleeding cells from pelvic calcium system onwards. They come in the urine as intact RBC. Those RBCs which get filtered from the glomeruli because of glomerular disease, they come through, they have to pass through nephrons, tubules, and during passing they become dysmorphic. So this phase contrast microscopy helps to diagnose whether this is glomerular disease which comes under nephrological specialty, or this is urological specialty that's bleeding from pelvic calcium system onwards or not. So if it is diagnostic only if the RBC, more than 80% of RBCs are dysmorphic, this indicates glomerular disease. More than 80% are isomorphic, it indicates bleeding from urinary tract. So this is a broad boundary between these two, glomerular and urinary diseases. Urine culture helps to establish diagnosis of UTI as a cause of RBCs, and urine cytology helps whether there is malignancy is a cause of bleeding or not. So these are the investigations we do in the case of hematuria. Similarly, blood investigation can help you. This renal function test, deranged renal function test will tell you the patient is having glomerular disease. Similarly, coagulation profile, if there is deranged coagulation profile, probably this is the cause of hematuria. What imaging helps you to make a diagnosis is simple is X-ray KEV, where you can expect radiopaque shadow, stone as a cause of hematuria. IVU again will show either stone or some tumors in the renal pelvic calcium system. Ureter, bladder will be visible in IVU. Similarly, USG will show either stone or tumor or presence of injury, trauma. These things are visible in USG and CT scan. So X-ray KEV is a simple one. Then intravenous urography, USG and CT are supplemental if you not able to make a diagnosis on the basis of simple investigations. So these are done in the order of preference, easier to difficult one. So for the evaluation, if even after these investigations you cannot make diagnosis, then cystoscopy is warranted. Cystoscopy, small lesions in the bladder, small or CIS, these may not be visible in ultrasonography or IVU or CT scan. So cystoscopy is done if the diagnosis is not established even after these imaging. And if you think glomerular diseases as a cause of hematuria, to establish a specific type of glomerular disease, you need renal biopsy. So these are extremes of investigations where if we do not have clues about diagnosis after doing all these investigations, we do these two investigations. So management. So management of hematuria as such is management of the cause. So in case of infection, we give antibiotics. In case of malignancy, we do operation for that. Infection of injury, we see how difficult it is, and we may need to explore the patient. So management of hematuria is management of the cause of hematuria. Microscopic hematuria in stable patient, you can investigate in outpatient basis, send investigations and call the patient after reports and make a diagnosis on the basis of investigation. But sometimes gross hematuria in unstable patient may need hospitalization for further evaluation and treatment. So in gross hematuria, sometimes it can be emergency. Patient passing a lot of blood in the urine can collapse and can become unconscious. So they need immediate management. So what we do if we get a patient of gross hematuria in emergency is you need to do grouping and cross matching. You see the hemoglobin, how much is he bled, then grouping, cross matching, coagulation profile, and so resuscitate the patient by appropriate fluid or blood transfusion. In many cases, the patient develops clot retention. That is, there is profuse bleeding inside the bladder or upper tract, and that comes in the bladder and that gets clot. That clot is of urine. That clot obstructs the urethra and the patient gets retention of urine. In this case, patient is restless with full bladder, comes in emergency. The management is you have to insert three-way Foley's catheter and manual evacuation of the clot and continuous bladder irrigation. By doing continuous bladder irrigation means you have three ways in this type of three-way catheter. Through one way, you infuse normal saline. Another way, you drain the washed urine. So three-way continuous bladder irrigation may be necessary if there is continuous bleeding, profuse bleeding inside the bladder to prevent further clot formation. And then once hematuria stops, then cystoscopic evaluation. Because in presence of gross hematuria, continuous hematuria, even if you insert cystoscope, you will not be able to identify the source of bleeding. So you admit these patients, resuscitate according to fluid and blood requirement, admit these patients, insert three-way Foley's catheter, start continuous bladder irrigation, and in a day or two, the irrigation becomes clearer, hematuria settles. Then do cystoscopic evaluation and see whether there is tumor or vascular abnormality. These are cystitis. These are shown by cystoscopic evaluation. So this is all about how do you proceed in the case of hematuria. The first thing you should be sure is whether this is hematuria or something else. Then next question is, if this is hematuria, what is the cause of hematuria? And third thing is whether this hematuria needs immediate attention or you can evaluate in the days or weeks time. So these are the three things important you have to keep in your mind during evaluation of a case of hematuria. Okay, and once you diagnose the cause, pathology, then you treat according to the pathology. So these pathologies we will discuss one by one in your 5th, 6th, 7th, 8th, 9th semester. So we will not go in detail about the diagnosis like stone, malignancy. We will not go in detail about these individual pathologies. These will be dealt in individual classes. Okay, this is all about how you proceed in the case of hematuria. You may get a question, a case of hematuria, how do you manage? So you have to list all these things. How do you, what history you take, what examination you do, what investigation you do, and what are possible causes in your mind. So finally, you will write the specific management depends on the specific cause. So that's all about today's class. Any questions you want to ask? Anybody? The 2 participants are there. Okay, if you don't have questions, we will finish, and if you still have questions, you can ask in another classes also. Okay.